and maybe we'd get 104 people at the meeting. So I became the consultant to the secretary as to what they do, you know, with this person, that. And I would sort of give my input. But at the same time, I was sort of intrigued by how young people would not come to a resource that was based in a institution such as a children's hospital for their services. They'd rather not come at all because the institution didn't understand their services. Or they would go to this alternative service, which was called a free clinic, the Los Angeles Free Clinic.
So before you get to that, tell about your institute with the AAP in Atlantic City. That's an important story, too, I think. I want you to go on, but I think
that was, thank you for reminding me. I was, when my division head came back, he was asked to...
We're talking about Dale Garrell, who would normally be here,
yeah.
but Iris is quite ill with bronchitis, and so both of them didn't come. That's why they aren't here.
That's right. And I'm using him a little bit as a foible. But when he came back, he was asked to do a workshop, or did he know anybody who can do a workshop at the AAP meeting in Atlantic City? And he turned to me and he said, you know, would you help me do a workshop on drugs? And I said, sure. He said, and also I want to do a workshop on general adolescent medicine. Now, you have to remember, I was pretty comfortable with all the contemporary issues of adolescence. But being an internist, I was not very comfortable with the developmental issues and the traditional issues that we often see in the hospital. And so, but I said, sure. I figure I can fake it. So off I go to Atlantic City, and we do this workshop. I invited some of the people who work with me in Montreal to come up and help, a psychiatrist from New York, who incidentally were the psychiatrists who, along with Erling and a fellow by the name of Watson, started the door in San Francisco. They were the ones who started the door. And I got involved in that by serendipity too. But anyway, they came and did this workshop. Well, I walked in the room, and it was a boardroom. It was a big boardroom table. And everybody in adolescent medicine, I didn't know at the time, Mike Cohen was there, Felix Heald was there, Ross Gallagher was there. All of these people were there. If I knew who they were, I would have fainted. But they were all there. And so I started giving my little rant about, you know, drugs and whatnot and how they interact with, you know, adolescents and all of that. And everybody's taking notes. And they're all crowded around this table. They're standing at the back. You could hardly breathe in the room because the oxygen was used up. I mean, it was just incredible. And they're all taking notes. And of course, I was having a great, I had no idea who I was talking to. So I came out, and everybody's coming and said, that was great, blah, 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 blah. And I said, oh, thanks. And then we went into, and I was feeling pretty good. And I said, wow, I was feeling validated. Because I was feeling validated in the sense that I was bringing some issues that were critical to contemporary adolescence to the minds of people who were in the Academy of Pediatrics, because the Academy of Pediatrics was not my home society. And so anyway, then the next day we went in to do this workshop. This was just like, I'm not sure what, I think the first one was a workshop too, but this one was in a theater. And I can remember this theater full of people. And Dale got up and he started presenting some things, and then, you know, we had decided he was going to do a little bit of physical development, and I was going to talk about psychosocial development. And I thought I knew something, and I got up there, and I'm going on and ranting a little bit about, you know, the textbook kind of approach, and somebody asked me a question, and I froze. I absolutely froze. I just panicked. I said, you know, it was like, this person realizes I don't know anything because they've asked me a question that needs depth to it. It needs understanding to it. It's not just repeating a fact that I'd read in a textbook. And I panicked. And this is my first major presentation as a fellow, and I fumbled my way through it. And then I said, Dale said, let's take a coffee break. So everybody went out for a coffee break. I said, Dale, I can't do this anymore. I can't. He said, you have to. He says, we've only done an hour of a 3-hour workshop. You know, you have to. I said, I can't. I really can't. I've never felt such panic in my life. And so I kept to my word. I didn't do any more of that workshop. I sat down, and I sat in the front row, and I watched Dale, and Dale did a nice job, you know, as Dale can do. He just carried it through. And I sat there, and if somebody asked a question I knew an answer to, Dale would turn to me and, give me. And I walked out, and I said, wow, what was that all about? And where it came from, it's like there wasn't a sense of congruence between my presentation and my knowledge. And I really felt that I was not being honest in what I was responding. I didn't really know my substrate. I didn't know my subject. And I refused to do any more teaching after that in the academy or anywhere, for about a year after that. I just refused because I just didn't feel confident at all. Well, at the same time, I was looking at how I can move some of the training for the residents from the hospital into the community. And that was, I think if there's things that we could underline that maybe I introduced into the field was one, the concept of concern for the contemporary adolescent, because there was not much going on in traditional medicine in terms of, going beyond the walls of the needs of the institution, the asthmas and the obesities, and the noncompliance and diabetes, but looking at STIs and drug use and risk profiles, risk factors, those kinds of things. These were things that I was interested in bringing into the field. And secondly, I was interested in somehow getting residents out of the hospital to get and sort of get into the context, of getting into environments which were indigenous to young people. I mean, hospitals are built for doctors. They're not built for patients. They're built for doctors, I mean, we put doors there for patients to come through, but that's only because you can't be a doctor without a patient, right? They're built, all the conveniences of the hospital are for the doctor. They're not for the patient. But when you go into an environment which is indigenous to young people, a lot of what's there is for the patient, is for the young person. And you feel uncomfortable. You begin to feel like what a patient must feel like when they come to a hospital, because you're now in their indigenous environment. And the free clinic was the perfect place for that. You'd walk into a free clinic, and instead of, giving some Thorazine or something for a kid who's flipping out, they had a crash room. And you'd go in this room, and there was cushions and music playing. They'd just get in there and enjoy their trip. They'd finish it off in this crash room. And there'd be in there a counselor who would just sit there and make sure they didn't hurt themselves. And then they would, finally, their level of their drug would go out, and they would, leave later in the day or early the next morning. And I sort of had to begin to rethink, well, what is it that we're doing? Can we train adolescents to be good patients? Or do we have to train the doctors to be very sensitive to what adolescents were all about? Because I think there's a big difference between being an adolescent and being a patient. Your patienthood is much different than your adolescenthood. And I began to get in touch with that. I began to see how we really abuse our role, not thoughtfully, but just by negligence. I mean, I cringe every time I hear somebody called an anorectic, because they're not an anorectic. They're a young woman who has anorexia nervosa. Now, you know that these people are perfectionists. And if you call them an anorectic, what are they going to be? The perfect anorectic. The use of language with young people is so important, And so I began saying, they're not patients, they're young people. And by understanding young people, you don't put them into your box, you put them into their box, and you have to understand their development, and you have to understand their development in the context in which they're growing up. And that began to change people's views of things. And that gave me the opportunity to develop the program in Los Angeles, which at the time I came down as a MCH fellow before they found out I was a Canadian. Well, before it was defined. I mean, I think we were awarded an MCH fellowship in '65, I think was the first one. And at the time, they were just physicians. There was no, LEA kind of approach of multidisciplinary involvement. And I think what I felt at the time, and again, naivete, absolute naivete, no intelligence involved. I felt that, what an adolescent physician had to be was not only a good physician, but also a good psychologist, a good social worker, a good nutritionist, and a good whatever you had to do to serve the needs of that young person. You had to have that was the uniqueness of being an adolescent physician. That's what we brought to the table. is this unique ability to expand our knowledge base to the core knowledge that's required of those disciplines which, interface with the adolescent's needs. So you had to learn counseling techniques. Some people here I know have been to my creative counseling workshop. That's where it comes from. It comes from that ability to take not the psychiatric or psychological model of counseling, but taking a mode of counseling which you can teach other docs to do. And it's in their language and it's in their purview of function that they can do 3-minute counseling, but they can't do 1-hour counseling. They can do 3-minute counseling which doesn't require self-knowledge. It just requires a technique and an appropriate response to the young person. And that's what I was building as I was there. And all I can say is thank God that Dale was not there the first year, because it left me the opportunity to be what I ended up being, was a physician who was becoming very eclectic in his approach to adolescent problems. And I think as our fellowship grew, more and more people came and benefited from that. And some of them are in the room. I see Manny Scheidlauer back there. Some of the older physicians, such as myself. Yeah. And I think Manny would say that, in the early days of adolescent medicine, there was a whole other emphasis. We didn't have the multidisciplinary team. We didn't have the, all of this people behind us. And I remember talking to Hilary Millar, the Hilary Millar Award, she was the head of the office of the Bureau's office. What was it called then? It was head of adolescence, I think, or something like that. Yeah, I turned to Trina for prompting. But
at one point they did call it the adolescent branch.
That's right, the adolescent, that's what it was. And I was describing what an adolescent physician needed to be. And then, this is like 2 years out of my fellowship, Mr. Adolescent Knowledge here. And so I'm describing what an adolescent physician should be. And I drew this daisy, and I said, at the center of the daisy is the adolescent. And everything we build around that must address the issues of the adolescent, the center of the daisy. And on each leaf of the daisy was a body of knowledge, social work and psychology and medicine and nursing. And around that, where the daisies interlap, where the petals interlapped with the daisies, that was the amount of that knowledge base a physician needed to absorb. And then those which were beyond that, where they interlapped, was a part of where you needed to call in the expert, so to speak. And she was fascinated by that. And she kept referring to the daisy model of Los Angeles. And then they introduced me as, I was the person who started this daisy model. Well, if anybody knows Los Angeles, if you were called a daisy model from Los Angeles, it was not a compliment.